Now, lastly, I'm going to discuss the care of children and adolescents with diabetes. Most of the young patients will have type 1 rather than type 2 diabetes. And before the age of 18 years, they may not have adequate ability or understanding to sufficiently care for themselves. And so the parents or an adult caregiver must be involved, and they must be provided with culturally sensitive and developmentally appropriate individualized diabetes self-management education and support. Individualized medical nutrition therapy is especially important and should be incorporated into the overall treatment plan for young patients with type 1 diabetes. Attention should be paid to psychosocial issues and family stresses that can have negative impact on diabetes management. If necessary, the patient should be referred to a trained mental health expert. As regarding glycemic control, the majority of young patients with type 1 diabetes should be treated with intensive insulin regimens, including basal and prandial insulins, or with continuous subcutaneous insulin infusion, if available. They should check their blood glucose levels multiple times daily, including before each meal and before bedtime, and as necessary for safety when performing certain tasks or when having symptoms of hypoglycemia. And just as for the adults, the targets of glycemic control should be individualized and reassessed over time. And hemoglobin A1C of less than 7% is appropriate for most children. However, less stringent goals, such as A1C of less than 7.5%, may be more appropriate for patients who cannot communicate symptoms of hypoglycemia, those who have hypoglycemic unawareness, or those who cannot check blood glucose regularly. And even less stringent HbA1c goals, such as less than 8%, may be appropriate for patients with a history of severe hypoglycemia, have limited life expectancy, or have extensive comorbid conditions. On the other hand, a more stringent A1C goal of less than 6.5% may be set for those patients who can achieve such goal without significant hypoglycemia and without negative impacts on well-being or undue burden of care. One must also be aware that some autoimmune diseases are more prevalent in patients with type 1 diabetes, and the patients should be assessed for these conditions soon after the diagnosis and if the symptoms develop. In particular, serum TSH and antithyroid antibody levels should be checked to screen for the presence of autoimmune thyroid disease. And IgA tissue transglutaminase antibodies should be checked to screen for celiac disease. And blood pressure should be measured at each routine visit. Elevated blood pressure is defined as greater than or equal to the 90th percentile for age 6 and height for children, and between 120 and 129 millimeters mercury with diastolic pressure less than 80 millimeters mercury for adolescents. And hypertension is defined as greater than 95th percentile for the children and greater than 130/80 for the adolescents. And patients with elevated blood pressure should initially be managed with dietary modification and exercise. Pharmacologic treatment should be considered if target blood pressure is not achieved within 3 to 6 months. And for the young patients as well as the adults, the initial pharmacologic agent of choice for hypertension is either an ACE inhibitor or an angiotensin receptor blocker. The goal of treatment is blood pressure within the 90th percentile for age 6 and height for younger children, or less than 120/80 for children older than 13 years of age. Blood tests for lipid levels should be obtained when initial glycemic control has been achieved, and if abnormal, should be managed with optimization of glucose control and medical nutrition therapy. For children older than 10 years of age, the addition of a statin may be considered for those who continue to have LDL cholesterol level above 160 milligrams per deciliter or above 130 milligrams per deciliter, plus one or more cardiovascular risk factors. The goal of therapy is to achieve an LDL cholesterol level below 100 milligrams per deciliter. The patients should have annual screening for diabetic nephropathy by obtaining a random urine sample for albumin to creatinine ratio once they reach puberty or are older than 10 years of age, once they have had diabetes for 5 years. If the albumin to creatinine ratio is above 30 milligrams per gram, then treatment with an ACE inhibitor or an ARB may be considered. The patients should also have an eye exam to screen for diabetic retinopathy once they have had type 1 diabetes for 3 to 5 years, and which should be repeated every 2 years. And along with the increase in the rate of obesity, the incidence of young patients with type 2 diabetes has also increased over the past 20 years. It is therefore recommended to screen for diabetes among children who are overweight, namely those with BMI above the 85th percentile, or those who are obese with BMI above the 95th percentile, and those who have one or more additional risk factors for diabetes. The screening should be done once they reach puberty or are 10 years of age, and either fasting plasma glucose, 2-hour plasma glucose during a 75-gram oral glucose tolerance test, or an hemoglobin A1C can be used to test for diabetes in children and adolescents. And if diagnosed with type 2 diabetes, the patient should receive comprehensive self-management education together with their families, just as for type 1 diabetes. Patients who are overweight or obese should be provided with a lifestyle program that aims to achieve 7 to 10% decrease in excess body weight. And as for drug treatment, young type 2 diabetic patients should be treated with metformin if the initial hemoglobin A1C is less than 8.5%, which is then titrated up to 2,000 milligrams per day as tolerated by the patient. If the initial hemoglobin A1C is above 8.5% or blood glucose is above 250 milligrams per deciliter, and the patient is symptomatic with polyuria and polydipsia, then a basal insulin should also be administered along with metformin, starting at a dosage of 0.5 units per kilogram per day and then adjusted according to blood glucose levels. However, if the patient presents with diabetic ketoacidosis or hyperglycemic hyperosmolar state, then intravenous insulin should be given and then changed to subcutaneous insulin injections as acidosis and hyperglycemia resolve, just as for type 1 diabetes. Young diabetic patients should also be screened for pancreatic autoantibodies if such tests are available. Metformin should be continued if they are antibody negative, but should be switched to multiple daily insulin injections if antibody positive, since these patients may actually have type 1 rather than type 2 diabetes. A recommended hemoglobin A1C target for most young type 2 diabetic patients treated with oral agents alone is less than 7%. But more stringent targets such as A1C of less than 6.5% may be applied if it can be achieved without significant hypoglycemia or adverse effect. And for the management of nephropathy in young type 2 diabetic patients, urine albumin to creatinine ratio should be obtained at the time of diagnosis and then annually thereafter. For those with elevated blood pressure, initial management is to increase emphasis on lifestyle management to promote weight loss. But if the blood pressure remains above the 90th percentile or is above 120/80 after 6 months of lifestyle intervention, then an antihypertensive medication should be added. Just as with type 1 diabetic patients, either an ACE inhibitor or an ARB is recommended as the initial antihypertensive drug treatment. Young patients with type 2 diabetes should also be screened for diabetic neuropathy by performing a foot examination at diagnosis and then annually. Diabetic retinopathy should be screened for by performing a dilated fundoscopy or retinal photography at the time of diagnosis and annually thereafter. Prevention of neuropathy and retinopathy should focus on achieving the glycemic targets